you to our second webinar. And this time we have distinguished faculty, Dr. Abhijeet Wahegaonkar from Pune. He's an established hand surgeon. And today is going to talk on wrist arthroscopy, arthroscopic anatomy, and indications for the use. Okay, over to you, Abhijeet.
Thank you. Good evening, everyone, and thank you very much, Hitesh, for the opportunity to connect with live audience and then to share a little bit about wrist arthroscopy. And I'm going to talk about setup, the anatomy, and the indications. We'll run a few videos for people to understand what this is all about. I'm sure there must be quite a few in the audience who already are aware of wrist arthroscopy or must be doing wrist arthroscopy. But this is just kind of a refresher course for them and an introduction to this new, relatively new technique for the others. I do not have any conflict of interest regarding this particular presentation. So wrist arthroscopy falls in the purview of small joint arthroscopy. And when we talk about small joint arthroscopy, we are referring to the wrist, the thumb, the MCP joint, and there are a few people who even scope the interphalangeal joints. We're also talking about endoscopy, we're talking about foot and ankle arthroscopy and TM joint arthroscopy. So all these small joints can be scoped using specialized instruments, specialized scopes and optics, and with the availability of high resolution and high definition optics and cameras, this has become such a wonderful asset to the armamentarium of the upper limb surgeon or the arthroscopy surgeon. So the history of arthroscopy, I'm sure, is not alien to very many of you. And Watanabe from Japan was the pioneer of arthroscopy. And if you've seen these slides of these people performing arthroscopy, it's so surprising how they did this particular surgery or these procedures and advanced science, even in such difficult situations. And now we enjoy doing these scopies with very advanced instrumentation and optics. So it was in the 1990s that wrist arthroscopy started receiving its attention and was advanced by people from all around the world. But a few notable names are listed on this site, and they include Didier Fontes from France, Kazuteru Doi from Japan. PC Ho is a giant who continues to amaze people with his surgical skills and knowledge and techniques in wrist arthroscopy. Ricardo Lucchetti, Andriadze, Geisler, Tommy Lindau, Luc Desmet, and my mentor, Christoph Mathula, and of course, Bill Geisler from the US was the father of wrist arthroscopy. So why do we talk about small joint arthroscopy? And to plead my case, I would like your attention to this particular slide and this picture where it shows a man trying to peep into the eye of the needle. And then if you zoom into the eye of the needle, you'll see this beautiful craftsmanship into that little eye. And so arthroscopy basically gives you the opportunity to look into joints with high resolution and high definition. And it is like performing microsurgery within a joint using these specialized instruments. And it's very interesting to see that way back in 1979, Chen said that arthroscopy is the gold standard, not only as the diagnostic tool, but also the technique of choice for treatment of very many disorders of the wrist joint. So what are the indications for wrist arthroscopy? And they are highlighted here. And this is an ever expanding list. And it's very amazing how in the last few years, wrist arthroscopy has advanced by leaps and bounds. So if you were to classify the indications into diagnostic, ectomy, tissue shrinkage, and surgical release procedures, or reparative and reconstructive procedures for soft tissue and bone, you can see that there's a litany of indications that you could address with wrist arthroscopic techniques. So let us go to the material and setup. So how does wrist arthroscopy differ from other arthroscopies? It is different in the sense we are using small and very delicate and fragile instrumentation. So the scope is either a 2.9 or a 1.9 millimeter scope, which is short in length. It has a 30-degree angulation, but 70-degree scopes are also available. And the trocar is blunt so as to not cause injury to the cartilage as you enter the joint. And um, we used to have this problem of reduced visual field and lesser definition, but that is a thing of the past now with extremely high resolution cameras and optics that are available. So the 30-degree visualization angle allows you to look into different nooks and corners of the joint, and a 70-degree angulation would allow you to look into very acute angles and improve your visualization. Not very many fancy instruments are usually required for wrist arthroscopy, and we always say that a fine curved Halsted or hemostat forceps is an arthroscopist's best friend when he's performing wrist arthroscopy. You do, however, require a small hook probe, a basket forceps, and a grasping forceps, and a 15-degree scalpel blade. These are the usual instruments that are required. However, if you have access to these fancy small shavers and burrs and RF probe, it only helps you expand your therapeutic procedures and indications for wrist arthroscopy. It's not a new adage that the probe is the arthroscopist's extension of the finger. It allows you to assess the texture of the cartilage, the tension in the ligaments, reduction of the articular fragments, or to measure articular step-offs. So the operative setup is pretty standard for wrist arthroscopy. The patient is supine on a standard operating table. We use either regional or general anesthesia. Tourniquet may or may not be used. PC Ho from Hong Kong uses only portal site local anesthesia. The shoulder is abducted to 90 degrees and the elbow is flexed to 90 degrees. And the only difference in any other arthroscopy and wrist arthroscopy is that you use distraction to create the space that you would like to work within the joint rather than insufflation using saline. So this is a standard setup for wrist arthroscopy. We'll come to that in a bit. And the traction provides you the space to work within the joint. So you can work in the radiocarpal, the midcarpal, the STT joint, and even the carpometacarpal or the MP joint or the IP joint whenever you would want to. And that's how the scope comes in into the radiocarpal and the midcarpal with the traction or the distraction that is applied. The distraction is usually about 7 kilograms or 8 kilograms distraction. There are several different finger traps that are available for fixing the or distracting the hand or the wrist joint. We use a hand holder, which is on the right side of your screen for accomplishing distraction. Fancy traction towers are also available that allow the hand to be brought out to horizontal position, especially when you're dealing with distal radius fractures with an arthroscopic assisted reduction and fixation. And when the distraction is applied, you insufflate the joint. We'll just come to that video in a short bit. So diagnostic arthroscopy, the patient positioning and the layout in the operation theater is illustrated in this particular schematic diagram. The assistant sits in front of the surgeon and the nurse is towards the end of the hand table, and your instruments will come and the TV monitor is on the opposite side. When you're performing surgical arthroscopy, you would want the assistant to hold the camera or the instruments every now and then for you. And therefore, the assistant is now at the end of the table and the nurse is in front of you when you're performing therapeutic wrist arthroscopy. Having talked about all this, how do we enter the wrist joint? And for that, the portal anatomy is of paramount importance. So the wrist joint can be approached either from the dorsal or the volar aspect from different areas. And the most common approach is a dorsal approach. And these portals are in relation to the extensor tendons. We all know there are 6 compartments of the extensor tendons. And then the portals are either referred to as 3, 4, 4, 5, 6R or 6U, or even the 1-2 portal for that matter. So what is essentially the lingo is that when you say 3, 4, the portal is between the 3rd and the 4th extensor compartment. When you're talking about 6R portal, it means that the portal is just radial to the 6th extensor compartment. When you're talking about a 4-5 portal, or when you're referring to the 4-5 portal, it means that the portal is between the 4th and the 5th extensor compartment. This particular cadaver slide will show the red dots. They are courtesy of my friend Max Herrle from Germany. Professor Herrle had done these dissections in France. And the red dots highlight the radiocarpal portals. That is, they allow you access to the radiocarpal joint. The yellow dots highlight the mid-carpal portals. And there are two portals. The one towards the radial aspect is the radial mid-carpal portal, and the one towards the ulnar side is the ulnar mid-carpal portal. So there are two mid-carpal portals. Now, it is extremely important to understand and to know the surface anatomy so as to not injure either the tendons or the dorsal sensory branches. And therefore, once you make a nick into the skin, you use a blunt hemostat to spread the tissue so that you can enter the joint. And if you were to think of the wrist joint as a box, you could approach this particular joint from any which direction except from perhaps caudal to cranial. So you have approach from the dorsal aspect, you have approach from the radial aspect, the ulnar aspect, the volar aspect, and you could then even use the DRUJ portals to perform your arthroscopy. So after the traction is applied, the anatomical landmarks are easily palpated. I'll skip these slides because I'll show that to you on a video so that it's easier for you to understand. But suffice it to say that the Lister's tubercle is the lighthouse for the wrist joint in terms of bony landmarks. That's the easiest palpable bony landmark. And you first identify the Lister's tubercle, and then you go on to identifying the different bony landmarks and the soft tissue landmarks, and thereby you could then mark your surgical portals to enter the wrist joint. So one good way of identifying the soft spot is to roll your thumb over the Lister's tubercle just like so that you can palpate the mushy soft spot, which is usually corresponding to the 3-4 portal. And having done that, you can then also identify the mid-carpal portals, which are just a thumb breadth distal to the 3-4 portal. So this is the video that I share with you, which shows how we go about marking the portals. I am first marking the Lister's tubercle, the tip of the ulnar styloid process, which gives me a rough idea as to where the distal ulna would be. So I mark that out. Then I mark the distal radius, just like so. Understand that the lunate fossa is a little proximal to the scaphoid fossa. Then I'm marking out the EPL, the basis of the second and the third metacarpals here. Then I mark the extensor carpi ulnaris, which is just dorsal to the tubercle, to the Lister's, to the ulnar styloid process with the forearm inthronation. And then I know from the soft spot, which is just distal to the Lister's tubercle, where my 3-4 portal is, right there. And once we have the 3-4 portal, you bring in a saline-filled syringe and you insufflate the joint with about 3 to 5 ml of saline. And then you look for the pushback from the pressure on the piston, and you know that you are within the joint. So the piston goes back and you know that it is within the joint. Once you have marked a portal, you would then bring in a 15-number scalpel blade. Remember not to use a 11-number blade because there's a risk of plunging in and damaging the soft tissues inside. And then I bring my hemostat after I've just nicked the dermis and nothing more. And we spread so that we put all potential structures that can be harmed out of harm's way. You feel the plunge, bring in your blunt trocar and cannula, and you're within the joint to begin your diagnostic round of wrist arthroscopy. And that's a 1.9 millimeter scope that we're using out there. So once we are within the joint, the sequence of viewing is pretty standard. We view the radiocarpal before the midcarpal, radial before ulnar, distal then proximal, palmar then dorsal, and ligaments then cartilage. Now there is no fixed rule of doing this. It's just that if you follow a fixed sequence of viewing, you will very seldom miss any pathology or any problem in the wrist joint. These are cadaver dissections, again, courtesy of Professor Max Herrle. The black pins are in the mid-carpal joint, the dorsal skin and the tendons have been removed, and the carpus has been flipped. So this is the scaphoid fossa, this is the lunate fossa, this is the ridge between the two fossae, this is the distal ulna. And these are the portals that are being marked. 1, 2, 3, 4, 4, 5, 6R and 6U. You all know what I'm talking about. And then you go about viewing the joint in the sequence that I just mentioned. So you first look at bony structures, which I've highlighted here. The carpus bony structures are the scaphoid and the lunate. And then you look at the ligaments, which are the scapholunate, the TFCC. The lunotriquetral ligament is not very well visualized from the radiocarpal portal. So what do you see? You see the radioscaphocapitate, the long and the short radiolunate ligaments, the scapholunate ligament, and the ulnocarpal ligaments, the TFCC, of course, and the dorsal and the volar aspect of the TFCC. And then this is how your viewing sequence would be. You go from radial to ulna, from distal to proximal, and bony structures and soft tissue. So this is a small video showing a dry view of the wrist joint. This is the scaphoid. This is the styloid process of the radius. This is the soft tissue reflection of the capsule of the waist of the scaphoid as you go distally. And then you come back to the radiocarpal joint. Right there is a reflection of the capsule on the scaphoid. And when you come back, this is the ligament of test tooth. That is the lighthouse of the wrist joint. And what you see here is the scapholunate ligament, that is a tuft. And then you go ulnawards and you would see there's a little bit of synovium, but we'll see in other videos as to how it looks like. And that's where the TFCC, the ulnocarpal ligaments would be present. Then you go to the mid-carpal portal, and the mid-carpal portal gives you a very good view of the dorsal aspect of the scapholunate ligament. You would see the lunotriquetral ligament, the lunate, the head of the capitate, the STT joint, and of course the triquetrum. So these are the different bones that have been highlighted here for your reference. And there's a trapezium and the trapezoid, which forms the STT joint. The ligamentous structures are again the scaphocapitate ligament, the capitotriquetral ligament. You can also see the capitohamate joint, and that is the sequence of viewing. Here in this video again, my hook probe is in the scapholunate joint. What you see on that side is the scaphoid, that is the head of the capitate, which forms the lighthouse of the midcarpal joint. That is a volar corner of the scapholunate ligament. This is the dorsal aspect, that is the head of the capitate I'm palpating. I'm now going into the introsseous part of the scapholunate, that is a dorsal scapholunate. And then you move your, that is a dorsal cornu of the lunate. So I'm viewing through the 6U portal, sorry, not the 6U, the mid-carpal, ulnar mid-carpal portal. And my probe is from the radial mid-carpal portal. So this is the usual sequence of viewing. Let's come to the therapeutic indications, which include TFCC injuries, distal radius fractures, scaphoid fractures, ganglion excision, and other procedures. And the list is ever expanding. Intrinsic ligament repairs and tears form about 38% of all wrist arthroscopy indications. And this is a video which shows you how a TFCC tear would look like. This is a peripheral tear. My hook probe is lifting up the tear. So this is what we call as the lift-off test or the hook test or the ghost sign when you put your scope underneath the TFCC and you can see it moving. And then you bring in your shaver to first freshen off the ends of the TFCC. This is a peripheral tear. There is no foveal avulsion. So we just use capsular ligament repair technique to repair this particular tear. And then you bring in your threads. We're using a hypodermic needle to weave them from the capsule into the ligament, the TFCC, and then you perform a horizontal mattress suture so that you complete the repair and the TFCC tension is restored. That is a relay of the sutures. I won't belabor too much on this slide, but this just shows you how a horizontal mattress suture is placed, and then you can tighten the suture to restore the tension in the TFCC and the repair is completed. So this is a peripheral capsulo-ligamentous kind of repair. If you have a foveal avulsion, which is highlighted in this particular slide on the left-hand side in a schematic diagram, this is a complete avulsion. So if you were to use the analogy of a rotator cuff tear, this is the bursal surface, this is the artery out there at the base of the fovea, and then you weave your sutures through the TFCC, and then you get your TFCC back to the base of the fovea. So this procedure is called as an arthroscopic assisted foveal reinsertion of the TFCC. So the idea is to, I'm sorry, so the idea is to get your TFCC back onto the fovea, just like so, using suture anchors. And again, now with the advent of different sutures, very fine sutures, push locks, and so on and so forth, this has become a very easy procedure to restore stability of the DRUJ in case the TFCC is torn. The other common ligament injury that you would come across is a scapholunate ligament injury. And this is a technique that we have published and has been published in several different journals and textbooks. We call it the arthroscopic dorsal capsuloligamentus repair. This is a schematic video just to help you understand how we do it. Of course, we first visualize through the 3-4 portal, then you make a 6R portal. That is a ligament tear, and there is a remnant on the scaphoid, a remnant on the lunate. You introduce your sutures through the scaphoid and the lunate remnant of the scapholunate ligament. You move to the midcarpal joint. Now my scope is through the ulnar midcarpal joint. I'm retrieving the limbs of the sutures from the midcarpal joint, and then we tie a Nicky knot, and you bring everything together, and then you tie another knot to bring the capsule and the ligament together so as to repair the scapholunate ligament. And then you would want to use pins at times to unload the ligament repair. And this is just a video, arthroscopic video to show how we do it. We are in the midcarpal joint now, and you can see my sutures coming in through each remnant of the ligament, one suture limb at a time. Then we get the other suture through the lunate aspect. And once we have done that, we retrieve the suture ends outside the skin, tie the knot, and then you pull it in. Remember, this is 2-0 PDS. A lot of people ask whether that proud knot causes any irritation. It does not, and it dissolves, and then is usually not a problem. And then you get very reliable and robust outcomes when you do this reparative technique for up to Mark Garcia Elias grade 5 of scapholunate ligament tears. Other indications are intra-articular fractures of the distal radius. This is something which has been very widely elaborated by Del Pineal from Santander, Spain, and especially for die-punch fractures, especially for intra-articular comminuted fractures, this is a very, very good adjunct to accomplishing articular congruity and then using minimally invasive techniques to fix these fractures. Not only does it allow you to get good fixation or good reduction, but it also gives you the opportunity to address any ligament injuries that may be concomitant with distal radius fractures. So this particular technique is very widely used by different surgeons. Other indications are scaphoid fractures. You can accomplish reduction using arthroscopy and then fixing the fracture and then assessing the fixation and the reduction arthroscopically and doing this in a minimally invasive manner. The idea is that you're preserving the soft tissue envelope around the scaphoid, and that kind of enhances healing rates and healing potential. So you can see after we remove the tourniquet, there is bleeding from the fracture ends and compression has been achieved. Another advantage is that you can very accurately place your screw. You can see if there is any over projection into the joint space, which can cause problems and cartilage damage if the screw is too long. Indications can be expanded to grafting for scaphoid non-unions. This is the classical scaphoid non-union with a cyst formation. You can see the cyst on a CT scan. And then these are, especially D1 non-unions, are some fractures that are, or non-unions that are amenable to arthroscopic reduction and fixation. Oops, my slide is not advancing. Just give me a moment. My camera and scope are in the ulnar midcarpal portal, whereas the radial midcarpal portal is being used to fill in the gap with morcellized cancellous bone, as you can see here. And we use a small cannula. We usually use the sheath of a hypodermic needle, which is transparent and also is big enough to enter the joint space and the portal. And then we place the bone graft and we push it in and we pack it in into the non-union site bit by bit, so that the non-union site is filled with bone graft, as you can see out here. And once that is accomplished, this is an intraoperative video, an arthroscopic view to show how the bone graft is introduced into the non-union site. It is extremely important to avoid any extrusion of the bone graft into the joint space. And once that is done, you will then bring the hand out to a horizontal position and then use percutaneous techniques to fix the fracture or the non-union site with a Herbert screw. You could also do arthroscopic styloidectomy in snack wrist. That is another indication. You could do distal ulnar resection, which is also called as the arthroscopic Felden procedure in case of an ulnocarpal abutment syndrome to relieve the pain. This is akin to doing an ulnar shortening osteotomy, except that you're doing it minimally invasive or an intra-articular procedure. Care has to be taken to maintain the cartilage in the sigmoid knot so as to not compromise the DRUJ. So you just remove the cartilage on the head of the ulna, and thereby you resolve the ulnocarpal conflict or abutment. So this is an X-ray which shows you preoperative ulnocarpal impingement, whereas here you have removed the head of the ulna and you maintain the DRUJ, which is seen in the arthroscopic video. Ganglion resection, again, is something which is very commonly done and is often we ask beginners in wrist arthroscopy to begin with the dorsal ganglion wrist ganglion excision to expand their experience. You can also put in partial implants such as the APSI implant and proximal pole non-unions with avascular necrosis. So you put in this pyrocarbon prosthesis into the joint so as to provide pain relief and maintain range of movement. Other indications are listed in this particular slide. I won't belabor too much on this. We can also perform arthroscopy of the carpometacarpal joint in carpometacarpal joint arthritis. For example, here we have to use a 1.9 millimeter scope. There are two portals, usually a radial and an ulnar portal. And then you put in your scope and then you identify the joint, visualize the joint, and then you put in your working portal on the radial side. Once you're inside, you can test the cartilaginous surface, look at the ligaments, and then you can do a hemitrapezectomy, tendon interposition, or you can put in gel foam interposition arthroplasty in case of arthritis of the CMC joint. So that is also something which is usually done and is possible. What are the prospects of arthroscopy? It is in describing new lesions such as the one that we have described, which is injury to the capsuloligamentous septum in scapholurate instability. It will be very nice to have flexible scopes and shavers, and it is akin to doing microsurgery in a high definition environment. So with that, I thank you for your time and attention and for joining the webinar. Thank you very much.
Thank you, Abhi. Thank you very much for spending your time with us and I mean, a lot of residents would have really
Can you
benefited.
hear me?
Of course. Yeah.
Hello?
Yes. Yeah, Abhi, we can hear you.
Yeah, I'm terribly sorry about that.
No issues. Yeah, absolutely.
Apologize.
Hello.
So thank you very much.
Thank you. It's been an honor. I appreciate
Yeah,
it.
thank you very much for spending your time to discuss about wrist arthroscopy. I'm sure it's going to benefit a lot of people all over the world, and
So,
looking forward for more lectures.
thank
And I don't
you.
know if there is anyone waiting. Let me see if I can take any questions. And
Yeah, sure.
someone is waiting because of the technical glitch.
Yeah,
They would
yeah,
have come and gone. Some of them,
I know.
no issues. So that's not a problem.
Thank you. Thank you so
Yeah,
much.
thank you very much. Since no
Thank
one is
you.
there,
Yeah.
and no one to take any questions. So, looking forward for more webinars, and I think we should solve all these technical problems next time.
Sure, sure, sure. Thank you.
Thank you, Abhi. Thank you so much.
Thank you.
Yeah,
Bye-bye.
bye bye. Yeah.